inflammatory stress, secondary to trauma, and hypoxic stress, secondary to cardiovascular insufficiency, pulmonary insufficiency, and obviously the inflammatory stress promotes the hypoxic stress, and this gives the patients complications and retards recovery. The surgical stress response has many different paths, and I don't have time to go into all of them, but basically all of the issues that make the patient not in their pre-surgical condition is due to the surgical stress response. That means pain, nausea, ileus, respiratory insufficiency, vasodilation, and there are many ways to attenuate the surgical stress. Minimally invasive surgery is being used, afferent nerve blockade, pharmacological interventions, and a whole range of other interventions, glycocorticoids. We have many ways of attenuating the surgical stress. One of the specific consequences of surgical stress response we're going to talk about today is the cardiovascular stress response, which is mainly sympathetic, due to afferent nerve stimuli and sympathetic activations of the cardiovascular system, but we also have a humoral stress that promotes cardiovascular complications. And I'm going to talk specifically about how to intervene on that, what has been done, and how this interacts with anesthesia and how we conduct anesthesia, because in most of these studies, anesthesia is just a black box. And in perioperative interventions is something that we just put on top of this black box, and we don't really talk about what do we do with the patients and how do the different actions that we do impact on the patient. This is a classical way of describing anesthesia. We have hypnosis. That means the patients can't remember what is going on, what has been going on. We have analgesia to attenuate the sympathetic stress, and then we have muscle relaxation. That can either mean that the patient just is relaxed or that we have specific neuromuscular block that allows the surgery to go on. This concept is actually based on this old paper from the 50s, and it has been known as the Liverpool method of anesthesia. This has been done with volatile anesthetics, long-acting opioids, and a lot of neuromuscular blocks, because we couldn't give a lot of opioids because they were long-acting, so the patient would in that case not be able to breathe after the surgery, so we had to give a lot of neuromuscular blocks to make the patients lie still during surgery. This is the classic method of anesthesia called the Liverpool anesthesia, and it's also the foundation of modern volatile anesthetic anesthesia. If we look at that and compare that to more modern TIVA approach with high dose of short-acting opioids such as remifentanil, then we can see that with the classic method of anesthesia, we have a lot of sympathetic stress because the stress response is not attenuated by, for example, neural blockade or high dose of opioids. With more modern anesthetic techniques where we give high dose of opioids, we attenuate the stress response, the cardiovascular stress response, and we have an almost alleviated need for neuromuscular block because the patient is actually asleep. So when we do these different perioperative interventions, how do they interact with this? We never talk about this. We just make large pragmatic studies where we generally don't consider the type or method of anesthesia and how that interacts with the patient's physiology. One of the really horrific cases is this the POISE-1 study, where we said, well, patients have sympathetic stress. We want to attenuate that by giving them beta blockers so that they don't get stressed. And this huge study actually showed that beta blockers attenuate myocardial infarctions, but more patients died because a lot of patients got hypertension and they got strokes. So, is beta blockers the correct intervention? Probably not if you give them to all patients. Potentially if you give them to patients with high stress. Because we've shown, and there's been a lot of studies in that recently, that not surprisingly severe hypertension causes increased number of complications and also causes increased death among the patients, even short periods of hypertension. We don't really know whether that's due to low flow or just hypertension per se. But again, these studies do not really concern themselves with the method of anesthesia and how it's been done and how the perioperative interventions have interacted. Recently, it's been shown that if we just attenuate hypertension by giving norepinephrine after goal-directed therapy, where the patient has avoided hypovolemia, we can actually in this is mainly abdominal surgery, decrease mortality. So we should attenuate stress, but we should also optimize cardiovascular function. And if we just look at a model of general anesthesia, you can see it's quite obvious that if we have a method of anesthesia where our whole perioperative setup is so that we don't attenuate sympathetic stress, it's quite physiologically sound to give beta blockers. But patients who are vasodilated have suppressed cardiovascular function, then it's perhaps more rational to give vasopressors. So whenever we do these perioperative interventions, I start by that so that we just have this in our minds today, say, how do we actually do anesthesia? How does that interact with surgery? How does that interact with other perioperative interventions that we do? We can't just roll out a single intervention and say, this works for all, because all our perioperative interventions are context sensitive, based on patient comorbidity, procedure, surgical technique, method of anesthesia, method of analgesia, adjuvant, and our postoperative care. If we put in epidural blockade and laparotomy and the nurses don't take the patients out of bed, then we probably don't get any effect from that. So we have to remember this when we look at our perioperative interventions. They are context and physiologically dependent. And that's just to set the frame for today. And Ismail will now take you further into long-term consequences of perioperative interventions.